Morning, Dr. Nora. Morning, everyone. Since it's 10 o'clock sharp, Doctor, shall we just proceed with the session first?
Okay, let's do that.
All right. Yeah, just gonna proceed and record the session first. Yeah. So a very good morning, everyone, and Dr. Nora. So today, this is our 18th episode of Case by Case Basics. First of all, thank you all for attending the session for today, since it's a weekend. And before we move on to the session, I would like to lay down some ground rules. So, like previous sessions, this session will be recorded. And please keep your microphones muted unless prompted to unmute to participate in the discussion. So slides will be given after the feedback form has been filled for this session, which I will release later, the link after the session itself. And if you have any burning questions, please do feel free to type it in the chat box, or we will attend to them during the Q&A session in the end. So if you wish to ask Dr. Nora some questions directly, just use the raise hand function in the toolbar and unmute yourself to ask a question. And midway interruptions are not encouraged so as to ensure a smooth and enjoyable session. So later during the discussion session, just feel free to participate. And yeah, that's most of it for the ground rule. Moving on, so a short introduction to our speaker for today. Here we have with us today is Dr. Nora, who is currently a practicing colorectal surgeon in UMMC, which is UM Medical Center, and also a full-time lecturer and surgical coordinator for 3.3 UMMP undergraduate medical program and trainee examiner for postgraduate Masters of Surgery. So she graduated from National University of Ireland with a degree of MBBS, and she pursued her Masters of Surgery in UM and furthered her fellowship in PPUKM and also Royal Prince Alfred Hospital in Sydney. So yeah, that's for our short introduction. Before we move on to the case regarding intestinal obstruction, is there anything that doctor wants to mention prior to the session?
No, we can start. We should start.
Okay.
Okay.
So I would like to introduce our patient here today, who is which I'll call Mr. SBT, a 78-years-old Malay gentleman, and RN is as below. So he presented to the emergency department after experiencing epigastric pain for 1 day. Yeah, so moving on to the HLPI, so the pain is located over the epigastric region and is of acute onset, which comes and goes for the past 1 day and has been progressively worsening during every bout. And the character is described as colicky and waxing and waning during every bout of pain. And he's unsure of the number of bouts prior to presenting to the department. And the pain radiates from the epigastric region to the periumbilical region eventually, and is exacerbated by food or fluid intake and is relieved by rest prior to admission. So the PAN score was noted to be 10 out of 10, and then reduced to 2 out of 10 after administrating morphine in the emergency department. And after the morphine, because it's just a single bolus, so after the morphine worn off, the pain score eventually returned back to 8 out of 10, which is the same character. And there is also since he has a stoma bag, there is no stoma output noted for the past 1 day, of which he will usually empty 4 times a day. And prior to the incident, he also noticed that his bowel motions are more limited, which is the stoma output is more limited and reduced as well. There is no passage of gas through the stoma during that 1 day period as well. And however, also there is reduced in oral intake and reduced in appetite due to the pain. It's not that he doesn't really have appetite. And there is no vomiting or abdominal distension up to this point. However, sorry, there is no upper GI symptom. There's a typo there, sorry. So there's no upper GI symptoms such as reflux, hematemesis, or melena. and there is no fever, no loss of weight, no night sweats prior to the incident noted. So yeah, that is it for the history of presenting illness. So quite a straightforward one. And then moving on to the past medical history. So he has hypertension, which was diagnosed 30 years ago, currently on treatment and also compliant to treatment, currently under control with an SBP of 130 millimeters of mercury. So just have a recent spike to 200, SBP of 200 because of the pain. And also dyslipidemia, which was diagnosed 30 years ago, currently on Tristor. So there is also coronary artery disease. So which he underwent PCI during June 2021. Stented the left circumflex and also left anterior descending artery, the LAD. And he's currently on clopidogrel, which was last taken 1 day ago. And then they stopped it after he was admitted into the emergency department. And also has a history of left solitary thyroid nodule, which was investigated and found out to be a benign follicular nodule, and currently is still under endocrinology in PPUM follow-up. So there's no history of COVID-19 and has completed all 3 doses of COVID-19 vaccine. So that is it for past medical history. So just to be kept in mind that there is some cardiac event that happened prior to, there was in 2021. So for his past surgical history, he actually has stage 1 rectal sigmoid carcinoma, which was eventually resolved and with surgery, where I can't really trace back his latest CA date was on, his latest CA value is 1, but I can't trace back the date of that CA itself. So he was the rectal sigmoid carcinoma was completed, was resolved with non-restorative anterior resection with permanent colostomy, which I mentioned prior. There's a stoma bag, and he was planned to have a colonoscopy in October 2022, which was this coming October, for surveillance only. And other than the rectal sigmoid carcinoma, which is resolved, he also has a history of TURP and cytolithoplaxy, which was done in January 2017 in UMSC. And eventually that was resolved as well, even though there's a short period of lower urinary tract symptom, but eventually resolved with the operation itself. So again, surgical history, do keep in mind that there's a history of rectal sigmoid carcinoma stage 1, but eventually resolved with surgery now. And the next colonoscopy will be on this coming October. So moving on to the family history, his sister has a history of hepatocellular carcinoma and is currently receiving treatment. He cannot remember the stage and also what kind of treatment that she's receiving. His stepsister also has small intestinal obstruction and has passed away due to the complications of a disease. He can't really recall what caused the small intestinal obstruction as well. Moving on to the social history, is married with 2 children who are all healthy and well, and is currently living in a terrace house in Setapak. He's a non-smoker and non-alcohol drinker, which aside from that, before the diagnosis of rectal sigmoid cancer, which we mentioned prior, his diet was highly fatty with little fiber intake. But he started to take more greens after the surgery and after the diagnosis of rectal sigmoid carcinoma as well. All right, so that is it for the history itself. Dr. Nora, do you have any comments regarding the history?
Okay, so that's a decent history taking. What I would add here is risk factors pertaining to what he may have, right? So you should have a list of 10 differentials in your head. And looking at the presenting complaint, can you flash back to the presenting complaint slide? Okay, what would be the 10 differentials in your head right now?
Epigastric acute onset. If just from the history of presenting complaint, first thing that will come to my mind would be acute pancreatitis itself. And also gastritis will be possible. And also not to forget regarding possibility of a cardiac event, especially inferior MI. And epigastric region. So upper GI can be peptic ulcer disease, can be GERD itself as well, but rarely present with epigastric pain of such severity lah. And also that is most of it that I can think of.
Yeah, so most definitely in this patient, you never forget his cardiac history, yeah, epigastric
Yeah.
pain and anything around the chest, maybe a low lying PE, or even yeah, okay. So pancreatitis is, unless you can think about pancreatitis, you mentioned that he's obese, he might have high triglycerides. Mentioned peptic ulcer disease because he is on aspirin, okay, that could lead you to having, and aspirin is, you know, is an NSAID. But you must never forget cardiac event
Yep.
and anything related to the lungs of a lower lobe pneumonia or PE as well, lower lobes PE, that could give you this kind of pain. And in terms of the chest as well, don't forget pleuritic pain, right? Pleuritic pain from a PE, you can get that, or from a recent lung infection, you can get that as well. Pleurisy, pleuritic type pain. Okay, so these are very very sharp pains in the epigastric sort of lower chest regions. Don't forget those. Okay. Did you mention that he's overweight?
Uh, that no.
No, because those are kind of things that you need to rule out in terms of
Okay.
epigastric pain. Uh, in a way, like if you had previous surgery, maybe thinking of incisional hernia, ventral hernia. That is a factor that's affected if you're overweight. And in terms of hernia, you also talk about incisional hernia, things that cause incisional hernia to occur, such as connective tissue disease or obesity. And again, like any other hernia, BPH, you mentioned TURP that's been done, you mentioned LUTS that's resolved, but also chronic cough, okay, and constipation, okay. Don't forget that there is an incision in the midline, right? So that's a differential. Okay, so if you have 10 differentials in your head, you would know all the risk factors that you have to search to rule in and rule out. Okay, so I think it's quite extensive already what you've done, but don't forget the two things:
Yep.
lung pathology and hernia pathology. Okay, all right. Next one.
Yeah. The hernia really slipped my mind. I didn't think of that. Uh, Moving
And then
on.
also, of course, in your head, when you think of incisional hernia, of course, adhesional colic, right? So that also, you need to establish the history of adhesional colic by episodes of recurrent colicky abdominal pain that gets progressively worse over time. The classic typical history is that you get colicky pain that resolves first month, second month, it becomes worse and worse. Third month, it doesn't resolve whatsoever, or it gets quite more frequent leading up to the admission, right?
Okay.
Okay, so that's typical of adhesion colic. Thinking along the lines of cancer, think about any symptoms that could mimic recurrence or metastasis. Think about the liver. Liver, the left lobe is in the epigastrium, right? You can have left lobe of liver met. Okay, that is stretching the capsule, right? So don't forget all the organs that is in the epigastrium. Yeah, so you have got there from the skin downwards. You got skin incision, right? You got a muscle weakness, right? You
Yep.
got adhesions. small bowel or whatever. You got liver there. You got stomach there. You mentioned peptic ulcer disease. You mentioned it. You've got pancreatitis behind you, and of course, spine doesn't really tell you epigastric lah. Okay, so then they have other similar referred pains such as heart, lungs. You've mentioned those. Okay, all right, good. Next one. So think about in systems and think about the organ underlying the pain. Okay. Similarly for meds, right? Think about lung meds. Okay, in terms of meds. Okay. All right. Continue on.
So moving on to physical examination. So over the general inspection, he's a large-built Malay gentleman who is alert, conscious, and lying comfortably over the bed with an 18 gauge of cannula dated over 28th of July in the right dorsum of his hand, which is connected to IV metronidazole with one 500 ml of normal saline, which is not connected. He also has a nasogastric tube that is connected to a drainage bag with off-white color content. Later we'll show the picture, measuring up to 200 milliliter and capped at free flow. With CBD connected to a drainage bag, sorry, the typo over there, with concentrated urine up to 100 ml. So this is the NG tube drain, which is kept at free flow with off-white milky content. Then this is the CBD drain, which is quite concentrated with 100 ml of urine. So definitely not enough urine out for him for his build. Yeah. Moving on to the vital signs, blood pressure at 161, systolic BP is slightly high because he's in a quite a bit of pain during when they took the BP, with a pulse rate of 92 beats per minute with regular rhythm and also quite good volume. He's febrile, and then oxygen saturation 100% on room air with respiratory rates of 18 breaths per minute. Peripheral examination, capillary refill time less than 2 seconds with warm peripheries, no finger clubbing, no palmar pallor, with again the 18 gauge cannula on the right dorsum to IV flagell, with no conjunctiva pallor noted, and oral mucosa is dry and tongue is coated as well. So yeah, he's quite dehydrated since he's not new by mouth. Yeah, since he's new by mouth, sorry. So moving on to the abdominal examination. So a general inspection over the abdomen, it is distended with a well-healed laparotomy scar. And it moves with respiration with a non-displaced umbilicus. There's no visible movement over the abdominal wall. And there's a stoma over at the right iliac fossa. So the stoma itself is flushed and has a pink mucosa. And it only has a single lumen, which supports the history of construction of an colostomy. Yeah. It has minimal fecal content and a dislodged Foley's catheter. With the surrounding skin of the stoma is normal and is not swollen, and there's no discharge from the underlying skin itself. So yeah, let's have a look at the picture. So this is the abdomen itself is quite distended. So that's a CBD with a midline quite well-healed laparotomy scar. And this is the stoma over at the, sorry, the labeling got some, yeah, never mind. Yeah, it's over at the right side with flush and also fecal content with dislodged Foley's catheter.
Yeah, so the stoma is on the left side, yeah?
Oh, sorry, yeah.
Okay.
Yeah, sorry, because I made this slide a while ago, sorry.
Okay.
Yeah, ignore the labeling. Later, I will make the correction. Yeah, colostomy left here. So, closer look at the stoma bag. There's not much fecal. There's not much content with the content, whatever that there is in the bag is fecal content, and the mucosa is quite pink as well. So the skin, overlying skin is normal. So moving on to the palpation, abdomen is soft and non-tender, and there's no mass felt over the 9 quadrants. There's no hepatosplenomegaly, and kidneys are not ballotable bilaterally. Percussion shifting downwards is negative, and chop space is resonant. active vowel sound is heard during auscultation. However, there's no tinkling vowel sounds and no aortic or renal bruit noted. Cough impulse is negative and there's no bulge over the parastomal region when performing the cough impulse. Yeah. So I didn't perform the digital examination of the stoma because I got it from the EMR. Reviewed digital examination over the stoma reviewed a patent lumen with impacted stools within the stoma itself. And digital rectal examination is not performed. And moving on, last but not least, moving on to the legs, there's no bilateral pitting pedal edema. So of course, during the physical examination, I would like to review the charts of the NG drain and also CBD train, the trend of the chart itself, whether it is positive or negative. Yeah. Yeah, that is it. Before we move on to the summary, for the PE doctor, is there anything that we need to take note of?
No, I think that is complete. Did you mention vowel sounds?
Yep, it's active but not tinkling.
Okay.
Moving on to the summary for history and physical examination, Mr. SBT is a 78 years old Malay gentleman who first presented with epigastric pain that radiates to the periumbilical region, which is colicky in nature and is exacerbated by oral intake, along with symptoms of constipation, which is suggestive of incomplete intestinal obstruction. On a background of, he also has a background of retoximoid carcinoma that is treated with non-reversible anterior resection and permanent colostomy. And he also has history of coronary artery disease, hypertension, and dyslipidemia. Upon examination, there is a healthy and patent stoma with distended abdomen and active bowel sounds. So he was to be planned for the summary itself, he was to be planned for conservative treatment, which is IV maintenance fluid and NG free flow. Aside from maintenance fluid, also, I forgot to add in, there is IV antibiotics and NG free flow with stomach output charting. It was to be kept new by mouth and also to be sent for CT abdominal pelvis throughout tumor recurrence or to have a look at the stoma region. So yeah. So for the summary, Dr. Nora, is there anything to add on for the summary?
That looks sufficient. But your summary is too long.
Still too long.
In summary, you have to mention in 2 sentences
Okay.
what it is, what you've done about it, what are you going to do next.
Okay.
So to summarize, Mr. SBT, 70-year-old man with a background of rectosigmoid CA post-op, admitted for adhesion colic to rule out intestinal obstruction on conservative management.
Oh, okay. Okay. All right. Thank you, doctor. We'll make corrections to that later. Okay. Yeah. So provisional diagnosis first. Again, we did touch on this just now earlier in the HLPI. Again, our topmost provisional diagnosis will be adhesive colic over the small bowel with might be due to impacted stools as well. The point towards is that there is the character of the pain, there is colicky and waxing and waning kind of nature of pain. And also the site of pain is suggestive of small bowel in origin because of the periumbilical region. And it is again one of the most common site for adhesive colic. The pain is exacerbated by oral intake and only relieved by burping. And during examination, there's also abdominal distension and also reduction in stomach output. And going back to his history, he also has history of abdominal surgery, which might point towards the adhesive colic. And of course, we always need to think about the possibility of tumor recurrence needs to be ruled out later during the investigation itself. So differential diagnosis later, just now we did touch on it, but of course 4 is not enough. There's a lot of differential diagnosis that is to be discussed, and then we did touch on during the HLPI just now. So of course, gastritis being location due to the location of the pain, and again the pain is exacerbated by oral intake. But gastritis rarely causes colicky kind of pain, and with the previous history of abdominal surgery, that's the point away lah. And of course, we need to rule out the most serious one, especially peptic ulcer disease. But the lack of UGIBs, upper GI bleeding symptoms, and also the lack of history of reflux symptoms point away from this diagnosis itself. So inferior MI can also cause this kind of pain, and he has a history of cardiac event as well. So that's why, like what Dr. Nora mentioned, this is always needs to be kept in mind. And acute pancreatitis needs to be taken note of due to the location of the pain, but there is no history of alcohol use or previous gallstones. So again, like what doctor mentioned, don't forget about pneumonia, possibility of lower lobe PE as well, because pleuritic pain can present as such. Yep. So,
Okay, very good. Those are very good differentials. Remember, guys, all these different diagnoses, you need to exclude them, right? All of which are very severe if left alone. Okay, with gastritis, you can get persistence of ulcer. That ulcer can go to bleeding. Patient is having aspirin, right? Patient can die. Okay, patient can die from the aspirin and bleeding from that gastritis. Serious. Similarly, peptic ulcer disease, it's serious. Could be a perforated gastric ulcer or duodenal ulcer. Similarly, inferior MI is very serious. That will then not be a surgical candidate for anything, and we have to take care of the MI. Acute pancreatitis is also serious. I can tell you right now, there is a current existing case, not in our ICU, in another hospital, where a 48-year-old woman was operated on for adhesive colic when actually it was all along pancreatitis. Now this person is dying in ICU from necrotizing pancreatitis because they did the adhesiolysis, right? And could never extubate her. She never came off the SIRS from the severe pancreatitis that she went on to develop after their adhesive obstructive release of the band, supposedly. All right. So nobody knows, what is done at the time of surgery or what was the presenting complaint, but never miss pancreatitis. Anyone with acute pain in the abdomen gets an amylase. All right, and if the pain is more than 3 days, then you need to do your serum amylase. Okay, and this is an unnecessary operation, and this adhesive obstruction is such a misnomer. It's such a distracting injury that you just label them as adhesive obstruction when perhaps there are other causes such as a tumor, recurrence, right? Such as a thrombus, such as pancreatitis. Okay, so please, these differentials must be ruled out. Adhesive obstruction should and would be tackled only if you've ruled out the rest. Okay, so I'm not asking you to like overthink everything, but you rule out all of these important factors. Yeah, because if they are not tackled, you can get a sequelae of it, which is worse than the beginning. Yeah. Okay.
So yeah. So moving on, investigations, I just break it down to which that we would like to perform and also what has been performed later I will show. So basically the basic three, the full blood count, renal profile, and liver profile. So full blood count is just to rule out underlying anemia due to the history of malignancy itself from HB, and also if there is a drop in HB, the type of anemia itself. and to ensure that there's no underlying infection from the white count, and to rule out thrombocytopenia due to the ongoing antiplatelet therapy that he's on. Renal profile is very important in this case because he's been kept new by mouth and just worried that he might be dehydrated lah. And also another thing to take note of is underlying electrolyte disturbances, as from what I read, especially the older population, they tend to have pseudo obstruction because of electrolyte disturbances, especially potassium. And again, like I said, due to prolonged fasting and no fluid intake, there's a possibility of underlying AKI. So just to quickly rule out that via the renal profile. Liver profile, just to as a baseline of liver function and also nutrient optimization due to the history of malignancy itself. And coag profile because of the current antiplatelets for his coronary artery disease, and troponin I, CK-CKMB to rule out possibly presence of any myocardial infarction. And serum CEA as surveillance, as part of the surveillance due to history of colorectal carcinoma to see whether there's any spike which might point towards recurrence. Serum amylase, like it's a very like what Dr. Nora mentioned prior, so pancreatitis shouldn't be overlooked. So serum amylase elevation might signify any ongoing acute pancreatitis. Venous blood gas to rule out presence of any metabolic acidosis due to peritonitis or any sepsis. And ECG, again, to rule out presence of any STEMI. So moving on to imaging, PA erect, sorry, should be, yeah, correct. PA erect, chest X-ray, just to rule out perforation with air under the diaphragm, especially the right hemidiaphragm. And also erect abdominal X-ray, which to look at whether there's any enlargement of bowels, which signify any obstruction at the distal to the enlargement of bowels. And we can vaguely.
Sorry, Owen,
Yep,
can we just
yep.
not do any more erect abdo X-ray? That is what is done in the past when they
Okay.
used to count how many air fluid bubbles. They used to say if you have 5 air fluid levels, then you have IO. But technically, that's kind of not helpful because
Okay.
we know there's IOs, right? From the
Yeah.
dilated lobes of bowel.
Hmm.
We actually want to localize. So what we
Ah,
do now is do this supine abdominal X-ray. As you're lying supine, please pay attention, guys. This is a common question that we ask. When you lie supine, it's much better than erect because as the patient is erect, you have the transverse column flopping down into the midline, okay, and the sigmoid, don't know where it will be, maybe in the pelvis, all right? If you have someone supine, the transverse column will be pushed backwards towards the spine because they're lying back, and then small bowel will be in the midline. So in this sense, you have a better idea what is obstructed, whether it is small bowel or large bowel, because all the bowels are in position. Okay, you don't have a haustra or a overlapping sigmoid or transverse colon haustra in the middle of the abdomen. So hence, if you did see dilated loops of bowel in the middle or in the mid abdomen, that is mostly small bowel. If the patient is supine, if you have it on erect in a in the mid abdomen, you can have overlying haustras of sigmoids, less transverse, and small bowel that you can't make out what is the actual dilated loop of bowel. Okay, so we
hmm.
move away from erect. They used to do it to count the air fluid levels, but our objective is not to diagnose IO. We would see it from dilatation. Our objective is more to localize the IO,
Okay.
whether we want to wait or whether we want to intervene, depending on the severity of the IO, as into where it is. Then it will help us localize it better. Although the best is still CT scan, and the better still is do a full laparotomy, but we do not want to have unnecessary negative laparotomy. So
Hmm.
we do supine abdo X-ray. Erect chest, yes, for air and the diaphragm, but supine for abdominal X-ray. Yeah, it keeps the bowel in its neutral position. Yeah,
Okay.
not gravity. All right.
Okay. All right. Thanks so much, Doctor. And next would be CT abdomen pelvis to locate the site and cause of obstruction and also the patency of the lumen itself. And OGDS just to rule out whether there is any upper GI pathology, especially peptic ulcer or any ongoing gastritis currently. Last but not least, colonoscopy can be done from the stoma site, since he has a non-reversible stoma, to ensure the patency of the lumen and to determine the presence of any obstruction. But yeah. So
Okay.
yep.
So this to add, the upper scope and colonoscopy is not done as emergency to diagnose IO. We should not ever bowel prep anybody that you think has IO, right? You should
Mm,
not ever scope anybody that you think have IO, because you will be inserting a scope and inflating gas, right? And that will
mm,
make the balloon bigger and it will pop in the most unuseful time, the most
mm,
useless of time that you want to diagnose. So don't do upper lower scopes in to diagnose IO, because
okay.
it will pop, right? We
Mm,
actually want to decompress, not to inflate further. All right. So at the same time, in the same token, they will also not tolerate bowel prep, because as you can imagine, if you did bowel prep, all that extra gas and
mm,
peristalsis will then go into the obstructed portion, and that will cause an explosive bowel at that point, which also is completely unnecessary. It will upstage the tumor. Mortality goes more than 50%. Okay, so upper and lower scope is not useful to diagnose acute IO or incomplete IO. You can do it if the patient is having altered bowel habit, yeah, but not in IO with vomiting
okay.
as such. Yeah, you measure or you gauge the degree of obstruction, and mostly when you mention obstruction, you will never scope, but you can gauge the degree of maybe traffic or altered bowel habit, right? The slowness of
Mm,
the transit time. Then perhaps that is still suitable for what we call even like a gentle bowel prep, not even the full bowel prep. So in anybody with obstructive symptoms, I would suggest to always start with imaging, either X-ray or a CT scan rather than a scope, because simply you don't know how severe that obstruction is. By putting in a scope, you only see what the scope sees, you don't see what's beyond. So you end up inflating gas. Gas can pass
mm,
through this small hole, so gas keeps passing through to the point that you spend a lot of time trying to negotiate this small hole, and more gas gets through, and the proximal part of that bowel, which is already distended full of feces and air,
mm,
will just blow up, right? Without you even
mm,
noticing, or even if it didn't blow up, it will stretch to the point that it can go ischemic, and definitely without you noticing, because you're only focusing on what you can see at the scope while negotiating through a tumor, for example. So not a good idea to scope somebody who's obstructed. You can do it when they are having altered bowel habit or having a mild obstructing, obstructed, no, obstructing, yes, to diagnose. Maybe a gentle scope may or may not need to have a prep. Okay, but what's absolutely essential before the scope is to do a imaging. CT is the best. X-ray, if you can have it, CT is better. Yeah. All right. So this is please. It's like time and time again. It happens all over the world. People will scope someone who's obstructed and cause all sorts of problem, including death. Okay, so we don't need this. Yeah. So not the first instance, and would not be what you do to confirm an obstruction. Yeah, please.
okay.
Okay, thanks.
Yep. I remember that. Mm. And like just a follow-up point for what Dr. Nora has mentioned, bowel prep should not be used. And from what I read, they don't really use barium swallow if they suspect intestinal obstruction or barium enema if they suspect intestinal obstruction, as it will worsen the intestinal obstruction by just adding on the content of the already distended bowel. Until you rule out complete obstruction or until you rule out possibility of obstruction, then you can proceed to barium swallow or barium enema.
Okay,
Uh,
yes. agree. I add to Owen's point. Barium is harmful, and particularly if there is perforation of the bowel with barium leakage, it cause barium peritonitis, which is a chemical peritonitis, which is really, really very severe, very difficult to remove. It causes massive fibrosis and extensive scarring. Patient will never recover from barium perf. Okay, so we've moved away from barium. We go on to gastrographine, but only after you have decompressed the bowels. Okay, when you have decompressed everything and you want to kind of find where is the most narrow portion of the bowel, that's when you use the gastrography follow through. Okay, but other than that, we've moved away from barium in the small intestine. Move away also from barium from the colonic part because of the barium peritonitis. Yeah.
Okay. So yeah. All right. So this is the investigations that was performed and in the ward. So full blood count is actually considerably normal, especially for the hemoglobin, platelet, and white blood. There's no, it's all within normal range. Differential count is within normal range as well. And moving on to the renal function test. So potassium is just slightly hypokalemic, 3.2. So like mentioned prior, pseudo obstruction must be kept in mind when potassium is slightly lower, is low. But in this case, doctor, do we need to consider pseudo obstruction even though it's only a 0.3 difference?
Okay, when you read the electrolytes, it's one causing the other or making the other worse. Okay, so if you have electrolyte imbalance, it will cause ileus or it cause like a pseudo obstruction. If you do have an obstruction, it will cause electrolyte imbalance as you lose fluid. You lose the hydrochloric acids from the stomach, and then you have sequestration of fluid into the small intestine. So one caused the other, yes, but which one started first, you can't probably tell, but you can look from the history what happened. So in this gentleman, his history is only 1 day, and it's a low potassium, but that's not significantly too low. You can monitor this. Perhaps he's on any other potassium uh, losing agents or diuretics that you have to check. Okay. Yes, of course, you can use potassium chloride from your saliva, and you know that there is a Ng content of 200 mils already, and that's kind of a lot that he's lost. Okay, so we need to keep an eye on the fluid balance, the urea creatinine, make sure there's no dehydration and no excessive electrolyte imbalance. Because the only way you're gonna get a successful surgery for IO, right? Or the only way that you're gonna correct a pseudo obstruction, it is not a real IO, then you need to correct the electrolytes. Okay, maintain that within normal physiological levels.
Okay. Right. So it's more like a chicken or the egg first kind of phenomenon in this case.
Yes, and you need to correct both.
Okay.
You need to maintain the physiological balance. Yeah.
And moving on, so the liver function test, everything is within normal range again. Even the lactate is less than 2.2, 1.6 is still within normal range, signifying there's no ongoing acidosis itself. Calcium is within normal range as well. Yeah, so moving on to coagulation profile. PT is just slightly reduced, just 0.1 second, which is not really significant. Moving on to serum, but need to the coagulation, no, antiplatelet, nah, never mind. It won't affect the coagulation profile on, because it was started on clopidogrel, so it won't really affect the coagulation profile. So moving on to serum amylase, so again it is within normal range. So the diagnosis of pancreatitis is lower down the list already. Cardiac marker, high sensitivity CHOP-I is within normal range also. And in CRP is less than 0.5. CEA, like mentioned prior, is 1, so it's not raised. And venous blood gas showed it is PO2. So the PCO2 just slightly raised. But there is no acidosis ongoing currently. Yeah, there's no compensation, there's no acidosis ongoing currently also.
Okay.
Moving on to the ECG shows sinus tachycardia with now moving on to the PA erect chest X-ray, gastric bubble seen over the over the left side, but there is no air under the diaphragm. Sorry, no air under diaphragm over the right hemidiaphragm. Another typo there. Sorry. Moving on to erect. I think this is supine.
This is
Sorry, that's
supine.
my bad. Yeah, my bad. My
Yeah.
bad. It's supine.
So
My
you
bad.
can see beautifully that the transverse colon is in the natural position, and in the midline here you don't see house truss. So
Mm,
that means it's clearer to you what is obstructing.
yeah. So then again, it's the small bowel is dilated lah because it's already 4 cm. So yeah. Again, move on to CT abdomen pelvis. So as we can see, um, for the others, there's not much finding, but from what we can see here over at the stoma side, I don't know how to describe that, but there is multiple loops like stacking on top of one the other. So is that do we straight away jump to say that there's a possibility of parastoma hernia, or in this case, how do we describe that, doctor?
Oh, there's certainly no other loops of bowel in this image anyway. There are no other loops of bowel apart from what we can see there, which is the stoma. Okay.
Mm,
The parastoma hernia would be is other loops of bowel that is under the skin but above the muscle. So you have trapped bowel in there. So in this case, she doesn't like in this image. There's none of that, but you do see a lot of enlarged small bowels that are edematous, and there's some stranding around the small bowel. And they even go as far as to say that there is small bowel ischemia to be ruled out because it's also congested. Okay, this tells me that it could have been because of its proximity to the parastoma region. It could have
mm,
been a hernia that has automatically reduced. By the time we got the CT
oh,
scan, the hernia has reduced. Okay, so you see
mm.
some strandings just underneath the stoma. That's something that you can suspect. And
So
for
the,
him, this was the case. Yep.
mm. So the stranding, which is this part, is it, of the?
The strandings on the small bowel. So if you go, you have to look at the rest of the images up and down, transverse,
Oh, okay.
pelvic. You have to see that the rest of the small bowel looks pristine, a normal size, but this one has thickened walls, and the mesentery is a lot of gray, a lot of angry looking mesentery there, together with some free fluid. So this is very difficult CT to call whether there's actual ischemia or not.
Mm,
But definitely at the time of the scan, there is no hernia to be seen. There could have been a hernia that accounts for these changes in the small bowel. That would explain also the small bowel obstruction that you see on the abdominal X-ray. Okay,
okay. Mm,
and if you look at the timing of the X-ray and the CT scan, there has been a considerable lapse in which the patient was told to be nil by mouth and having an NG tube there. That would also help, okay, with the patient's resolution of IO. So as you can imagine, if the bowel is obstructed in a parastomal hernia, okay, as you relax, as the bowel doesn't get fed more and more water and food, it will continually have a peristalsis trying to escape the tightness of the hernia or the neck of the hernia. And as it does so, peristalsis will continue to release the hernia. All right. But if you
mm,
keep on eating, the bowel is just going to get more distended. Whatever that's trapped will become bigger, and it will
mm.
become worse off for him. Okay, to the point that it could rupture inside the parastomal region or rupture internally where it's most obstructed. Okay, so you can never really expect or anticipate where it would perf,
Mm.
but it would do so where it is most ischemic or where it is most distended. All right. So in this case, The bowels, by the time the CT scan is done, the small bowel is not large anymore. It's not very, very dilated anymore. It's already less than 4 centimeters.
Mm.
So you can see that there is peristalsis that has happened in between the two scans. And if you look at the correlate that with the history and the progress of the patient with the NG tube and nil by mouth, you can anticipate that this was a reduced stoma. However, having said that, even if the hernia is reduced, right, and there is all the small bowel, whatever bowel that was trapped is already now in the abdomen. Remember that hernia is not normal, and it being there actually causes us fibrosis that could cause scarring from the bowel wall to another bowel wall, causing like an adhesion within the hernia. Okay, so we call this reduction of hernia and mass,
Mm.
or reduction of the obstruction and mass. So it means that as the hernia plops back into the abdominal cavity, it is still stuck to each other. And when it is stuck, or while it is stuck to each other, it could still be obstructed. Okay, so this is why we never ever reduce a hernia ourselves. We must always tell the patient to reduce the hernia, because a hernia that is obstructed or is impending strangulation will never be able to be reduced due to pain.
Mm.
Okay, so patient will have extreme pain, so they will not reduce it. But if you go ahead and push it down, right, despite it being painful, um, you have no idea whether it's painful or not, because you're the one pushing it down. Only the patient will be able to stop it from pushing it down himself or herself if it is painful. Okay. Okay, so there's a few concepts here: parastoma hernia, um, ischemic bowel, reduction of hernia and mass.
Mm.
Okay, and the clinical manipulation of hernia is a no-no. Yeah, so these are main concepts that we discuss. A lot of people, like, well, of course, if you have no experience, you would not know. But if you saw a hernia in clinic, never reduce the hernia. Ask the patient to reduce the hernia, him or herself. And if they can't and it won't go down or it's painful, then it's considered as strangulated or impending ischemia or incarcerated. Okay, so
Mm.
even if you did manage to reduce it, yeah, for example, if you have a hernia reduction and mass, which means you have like a spider web around this bowel, forming a clump. Initially, the clump was in the hernia sac. Now the clump is inside the abdomen. Yeah, you will still get ischemia. Okay, because it's still obstructed, it's still strangulated within its own network of adhesions. Yeah, so please do not push a hernia. Even if a hernia is reduced, please observe, especially if the patient is obstructed, please observe that there's complete resolution of GI function to say that there's no further obstruction, that there's no further hernia that was pushed inside. Okay, no further obstruction. Okay, ensure that the patient BO and eats freely before you discharge someone with a reduced hernia. And always, because hernia is a structural issue, please fix it. If it gets left alone, it only gets bigger. All right. So the bigger the hernia, the more bowel content or any abdominal content can prolapse out. That makes it more difficult to reduce in the future. Makes the next surgeon or nobody want to touch this patient. Okay, in that sense. Okay, so hernia, fix it. Hernia, don't reduce it. Ask the patient to do it. Yeah. And remember, even after it's reduced, think about obstruction, think about ongoing ischemia. Okay, that could still happen. All right.
All right. Yep.
Just
Thank you,
because you
doctor.
see the problem no longer there on the surface, it can still be there on the inside, right? You just push
Mm.
the problem in. Okay.
Mm.
Which you, in that sense, you made it worse, and they could probably go home and die, right? That's what we don't want. But
Mm.
that's what happens, can happen, and it would happen if you don't know. And they will say sakit tua or
Mm.
whatever else, right? Okay. Okay, let's move on to next slide.
Okay, so yep, that's it for the imaging. So for the management, of course, intestinal obstruction, or when you suspect there is intestinal obstruction, first of all, with the primary survey, again, go through ABCDE and ensure patent airway with adequate saturation, which if the O2 supplement is not satisfactory on room air. And then two large bore peripheral cannula and provide adequate hydration, and also insert CBD to monitor hydration status and aim at 0.5 ml per kilogram per hour. And of course, the must do is to keep the patient nearby mouth, and then also keep an NG tube and aspirate for hourly, or keep it at free flow. And strict input and output charting, and also stomach output charting in this case should be done to just look at the trend to see whether the patient is dehydrated or not. And also, since adhesion colic, like the patient described, is a 10 out of 10 or 8 out of 10 when the medication has worn off. So analgesics can be given, such as subcutaneous tramadol in this case, of 50 milligram TDS was given, and downgrade to PCM when the pain is more tolerable. Since the patient has been kept new by mouth, so IV Pantol should be given for gastric protection. And last but not least, we need to start on prophylactic antibiotics as well. In this case, IV ceftriaxone and also IV metronidazole was started. And I think that's mostly it. Yeah. Anything to add on regarding the management?
Okay, in this patient IO, right? For
Mm.
IO, you must always think about is what is the cause, yeah? What can be decompressed? What's the extremity of the IO? You can have a very dilated bowel that will decompress through NG tube. You decompress from the top or from nearby mouth. But you can have an obstructed bowel that's compressed on two ends of the bowel, for which we call this a
Mm.
closed loop obstruction. Okay. If you have a distended abdomen, but patient's not vomiting, not passing motion, that but the abdomen is continually distending or is in pain, remember closed loop obstruction. This can occur from the obstruction to the site of an ileocecal valve or colon, or it can occur from any two sites that are stuck in a hernia, for example, or two sites that's compressed by an adhesion. Okay, so this is called a closed loop obstruction. Beware of this. Remember, the
Mm.
sequelae of obstruction is not always perforation. Okay, it can also be ischemia. All right, so bowel ischemia can happen, bowel perforation can happen, but even before that, if the pain is not controlled by a standard PCM trauma and you have to escalate to morphine, definitely ischemia is happening, definitely perforation has happened. Okay? Because PCM and trauma should resolve any colicky pain, but it would not resolve an ischemia pain, it will not resolve a perforated peritonitic pain. Okay? So
Mm.
looking at your analgesia ladder, the ladder goes up. You got PCM, trauma, then your opioids. If the patient's not controlled, think very seriously about it being ischemia. All right.
Mm.
Okay. So ischemia, by definition, is pain that is not matching the clinical feature.
Yep.
Okay, remember, your lactate can still be normal even though most of your bowel is dead. All right. The Diagnosis, as always and will always be, is clinical. All right. If you have a pain that's unnaturally bad, abdomen is soft but distended, okay, then even if the lactate is normal, please think about ischemia. All right. And you will see features of this on a CT scan. Number two, if you have an IO that you want to manage conservatively versus operating, right? Especially in adhesive colic, whereby maybe 80%, 50 to 80% actually resolved by itself with simple NBM decompression. Okay, because as I told you, as you decompress, you stop the loading of food and gas into the bowel, and the peristalsis will naturally happen and dislodge the the obstructing area or the kink in the bowel. All right. But if your decompression does not work, or the pain is persistent, or it worked for a while and then the pain came back, or it worked for a while, then patient becomes septic suddenly, then think closely about going in. Okay, there is a saying: don't wait for more than 2 days don't let the sun set twice on a small bowel obstruction. You go clinical. You have to examine the patient, you as in you alone, because if you get 10 people to examine the patient, there'll be 10 different findings. So what we mean here is a serial abdominal examination. If you're going off shift, the person who's coming to you to replace you should examine the patient with you and get gauge that this is the actual pain right now as you examine the abdomen. All right. And as you take over from the patient last night, the patient last night have to examine with you to say that this is exactly how the pain was last night. Okay. So this is called serial abdominal examination, which is more important than going in for surgery. Any monkey can do surgery. Okay. But serial abdominal examination, or when to do the surgery, is number one, when the patient become worse. Number two, if the pain is unrelated to the level that it's supposed to be. Okay, so if it's needing more and more analgesia. Number three, if patient gone septic. Number four, if there's peritonitis, if there's tenderness. Once there is tenderness, okay, there should be no doubt about you going into the abdomen. Okay, so tenderness. Pain is pain. Tenderness is elicited pain that you push in your hand and cause this tenderness. All right. So guarding is, of course, definitely you have to go in, and it takes a bit of practice, but you really need to differentiate what is guarding and what is voluntary guarding. You need to distract someone when you examine them so that you know that they're not actively guarding on command. All right. And then you probably need to examine a few different times yourself. Maybe if you're beginning in the junior stage, you could get your seniors to come and examine with you. And that senior will also have to examine this patient a few times, because once off, like anything that's once off, it's not the whole picture. Even your bloods, even your x-ray, even your CT scan, as you can see, the abdominal x-ray is different from the CT scan. Okay? Once off is never an answer. Okay? It can be something that people can sue you for, but you must do your serial clinical examination.
Okay.
Right? So a lot of topics here to be hammered into you in terms of what we need to look out for in this gentleman. Number one, IO. Okay. Remember also in the IO, as part of the complication, not only there's ischemia or perforation, there's also fluid shift. Okay, and with this fluid shift, with this distension of the bowel, with the congestion of the bowel, there's loss of the mucosal barrier. Hence, whatever germ or content that is in the abdomen, in the bowel lumen, will spread to your bloodstream, and that will cause a bacterial translocation, for which you must start antibiotics. Okay, so any IO with any elevated CRP or white cell count deserves antibiotics. Okay, because when there's a loss of this mucosa barrier due to congestion or ischemia or distension, then the bacteria will get into your bloodstream. You can get overtly septic simply because of obstruction. Okay, so IO is number 1 point. Number two, hernia. Okay, when to reduce, how to reduce, what can happen. Number three, what are the potential differences? Like when do you actually think about ischemia?
Mm.
Which is ischemia can happen even with a normal lactate. Yeah, and ischemia can happen even with a normal abdomen. And ischemia is because you have pain that's unrelated to the symptom or something like compartment syndrome, where the
Mm.
pain is worse than it looks. Okay, the patient looks like there's no guarding, there's no peritonitis, but there's extremely painful that cannot be explained. Another thing to look out for if you're thinking pain that cannot be explained in the epigastric region, especially if patient's hypertensive, aorta. Never forget dissection of aorta or even triple A. All right, that goes into the epigastric as well, especially the thoracic aorta. Okay, so that's really going all the way down to the level of spine, but that could still present as epigastric pain that's
Okay.
unexplained. Okay, so when you have extreme pain that's unexplained, think about a severe obstruction, ischemia, perforation, right? Perforation of gastric ulcer or dissection, aortic dissection is one of the other ones. Okay, so there's a lot to be discussed, and I'm glad you have discussed most of it. And these are just some pitfalls that you need to think about.
Okay. So yeah, actually that is the last slide already. Actually, the next would be just the feedback form. Yeah, so it's for the feedback form. So yeah, Dr. Ran did a very, very nice conclusion on what really to watch out for during intestinal obstruction. Even though by the books is fairly straightforward, but when it comes to clinical, it's really not that easy to determine when or not to go in and then what to watch out for. So yeah, hence this is the end for our case for today. Now we shall move on to Q&A session. So for those who have burning questions, just feel free to leave it in the chat box, or for those who are willing to ask Dr. Nara directly, you can just straight away use the raise hand function and then just unmute yourself and ask the questions. So, Dr. Nora, while we are waiting for the participant to ask questions, personally, I have a question myself. So, we see in the stoma, usually there's a Foley's catheter. Sometimes it's in the stoma lumen. So, is it like a way to decompress the bowel, or is it just to, like, what is it usually for?
Never in a functioning stoma should you insert anything into it. There's no point. That you don't put a Foley up the anus, right? Um, the why it's done is usually to help maintain the patency of the lumen. Okay, so for example, if the lumen is kinked or we think that there's something infected, we could put in this Foley to straighten out, so to speak, the bowel into the abdominal cavity. Sometimes when the patient's really fat, they can have a bowel that's going round and round before it goes into the abdominal cavity. Yeah, round and round under the skin. So this makes bowel bendy. So we could put in a Foley catheter to kind of straighten out or give like a certain pathway for gas at least to pass through. And at the same time, you can use the Foley to push in fleet enema that will help impacted stools. Okay, that would be useful. All right, but this is a colostomy. All right,
Yeah.
usually it's straight, but what could have happened is that we've created a opening on the inner abdominal muscle bigger than we needed to. Hence, smaller bowels like small bowel could be trapped. Another thing about a colostomy here, and colostomy especially, you have a organ that's supposed to be retroperitoneal. Descending colon is retroperitoneal. Yeah.
Mm.
But you hike it up all the way into the anterior abdominal wall, right? So you actually have this piece of colon going stretching from the retroperitoneum onto the anterior abdominal wall. So as you can imagine, it's like a pull on the inside You can imagine the small bowel can act like a stripper around the pole, going around and around the pole. Okay, and that could cause internal herniation as well. And sometimes this internal herniation can get into adhesions, it can get stuck. So it's really helpful not to see any small bowel lateral to the colon. We want to see all small bowel in medial to the colon. So the answer to your Foley catheter is one, you can straighten out, help straighten out the bowel. Two, you can put in enema through it, especially if you have impacted stools when you put your finger in. And I'm sure in this gentleman, your finger will not go into the abdominal cavity, it will be stuck in the fats level.
Oh,
All right, in the adipose tissue level, you're not in. So the Foley will help straighten it out. But in the normal circumstances, there wouldn't be any Foleys, just like you would not have an Foley up the anus. Okay, it's used, yes, one to decompress, two to straighten, three to put in enema. Another time that you could do this is to make sure that all the content comes out into the abdomen, to the stoma bag. For example, some of the stomas may have a dehisced skin. Yeah, the skin is dehisced around the stoma, so the stoma bag is like not very secure. So you really want all the content to go into the stoma. Yeah, so you create like a path, an easier pathway.
okay.
Most of the time, sometimes we see it, especially in those with a long distance between the abdominal skin and the abdominal muscle, say more than 5 cm, right? More than 5-10 cm before it gets to the internal abdomen. Sometimes the bowel can get kinked or becomes a little bit singing, especially if the abdomen is flabby. Okay, so if the abdomen is flabby, you can imagine the gravity pulls the skin down, but the muscle stays in the same spot. So the stoma is at an angle. So if you pass a
Oh,
Foley through into the abdominal cavity, you pretty much straighten the angle, or you create a pathway for gas to at least escape in the beginning. Yeah. All right.
okay. Is there any questions from the participants? Right, going once, going twice. Okay, so for the Q&A session, let's just end it here. So before we end this particular session, please do feel free to leave your feedback in the feedback form. And I've left the link in the chat box already, or you can scan the QR code for the feedback form on the screen. So a soft copy of the corrected slides will be emailed to you after you have completed the feedback form. So before we truly end the session for today, Dr. Nora, is there any take-home message for the listeners, for the participants, and also for me as well?
Yes. So when you have a sick patient with a pain score 10 out of 10, please don't leave his side until you have controlled the pain and done all you can to prepare for the resuscitation, like put in oxygen, IV drip, IV large bore, IV granulas, analgesia. You can never leave a distressed patient by themselves. Ideally, this patient should be in resus bay or in acute bay or in ICU. Okay, someone with 10 out of 10 is very serious. Someone with 10 out of 10 with a lot of pre-morbid such as him is ultra serious. And someone with 10 out of 10 whose daughters are doctors in Australia and the nephew is a cardiothoracic surgeon in Selayang and all this socially high risk patient, don't leave their side. Basically, don't leave any sick patient alone. Do what you can to alleviate the symptoms and get the scans and diagnosis as fast as possible. Okay? And do the serial abdominal examination. I have to stress here the serial abdominal examination is what is done by you and you alone to repeat it to see if there's improvement or deterioration. No one else have a better say than you who first saw the patient. Okay? So that's why it's very important. Yeah? take-home message. Don't leave the patient side. Do the eyeballing yourself. Okay, that's all. Yeah.
Oh, sorry, doctor. Just sorry. One more question that came into my mind suddenly. For the NG free flow, the NG tube drain, um, do we completely take it off until when the drain goes to zero, or as long as there's a downwards trend and we see patient getting better, we can just take off the NG tube already?
So the NG tube is very uncomfortable to have in, and it's very uncomfortable to put in. So you must remember, once it is in, you only take it out if you're sure that you're never going to put it back in again. Okay. Number one, because you already had a previous NG tube, it will be raw on the one side, right? So you have to put the NG tube on the other side, the other nostril. Okay. So that means the time that you redraw the NG tube is only after the feeding is established. All right,
Okay.
which means if they can tolerate liquid, they can tolerate oral feed, they should take it out. So liquid up to nutrition, sometimes what is it? So clear fluids is okay. You keep the NG there, but you spigot it. Make sure that the fluid goes down and the NG output is zero. And then when you can upgrade to nutritious, like milk or like porridge, you can leave it there and spigot, but you can also remove it. Okay, by the time that you allow them oral nutritional fluids or milk, by that time you can allow the NG to be removed. Okay,
Okay.
but be careful of those who have distal or very very distal small bowel or distal large bowel obstruction. They don't vomit up. Okay, they tend to keep all the food all the way in the small bowel, all the way to the side of the blockage, which is quite distal, and then they vomit 3 to 4 days later.
Oh,
Even after they could eat quite well for 3 days, they'll vomit 3 days later. So in those patients that you can see is a distal small bowel, you keep it for longer, at least
okay.
until you've done your small bowel gastrography and follow through. And when you've done that, you can see that all your contrast has gone into the colon or out the anus, then you're sure that you can remove the endotube. Yeah,
Mm,
because only because it's very painful to reinsert.
okay. Okay. So last call. Any questions from the audience? Okay. So once again, Doctor, aside from the take-home message just now, anything else that you want to reiterate to the audience today?
No, I think that's about it. Just feel
Okay.
free to ask questions as you go along. Don't be shy.
Yeah.
Questioning is better than assuming. Okay.
Again, going once, going twice. Okay. Yeah. So once again, thank you so much, Dr. Nora, for the
My
session
pleasure.
today. And also thank you for those who attended, and also especially during weekends. The feedback from screen, I'll be leaving it here. And yeah, that is it for our session today. Right.
Okay, thank
So,
you, Owen, for chairing the session. I am very honored.
all right. Thank you so much, Doctor, for attending in the new weekend some more. Right.
Okay, take care.
All right. You too, Doctor.
Okay, thanks.